Hello and welcome. Today we have received the medical files of 53-year-old Catherine Dexter. Catherine has been experiencing symptoms that often occur with pancreatic cancer, such as weight loss, pain in the abdomen and back, and steatorrhea. After looking through Catherine's family history, we have found no genetic link to pancreatic cancer, but other forms of cancer have been present in her bloodline. We have detected a mass in Catherine's pancreas on a CT scan and have decided to perform a biopsy. We took samples from the tumor in her pancreas as well as from the healthy pancreas cells around it and ran a microarray. Through comparing the microarrays of both samples, we've discovered some genes in the tumor to be turned off. One such gene is the KRAS gene, which has the normal function to promote cell division. Genes controlling cell division are also called proto-oncogenes. This proto-oncogene has transformed into an oncogene, or a gene that has the ability to turn into a tumor cell. When a proto-oncogene is mutated, cells begin to divide uncontrollably, forming a tumor. Mutations in the KRAS gene are found in 75 to 90% of pancreatic cancer patients, and mutations of the gene AKT2, another proto-oncogene, are found in 60% of pancreatic cancer patients. AKT2 also creates a protein product that inhibits or prevents cell death. This protein allows for cancerous cells to continue to divide while not killing them off, allowing the tumor to grow. We believe these proto-oncogenes were attacked by microRNA, a cellular RNA fragment that prevents the production of a particular protein by binding to and destroying the mRNA that would have created the protein. The third gene mutation we found was in the TP53 gene, which is a tumor suppressor gene, critical in the life or death decision in abnormal cells. More than 50% of patients have a loss of function in this gene. With these three genes malfunctioning, cancer cells are able to divide without any forces acting against it, allowing for cancer formation. In addition to the DNA microarray, we use imaging techniques such as endoscopic retrograde cholangiopancreatography, or ERCP. ERCP is a technique in which we use an endoscope to inject dye into an area of interest that will enhance our X-ray image. ERCP is similar to using probes when detecting genes, which will help make specific genes visible by containing the complementary sequence to the gene and attaching itself. While biopsies are not necessary prior to surgical procedures, it is usually required before we administer therapy, so we went ahead with the biopsy. We have received our pathology report back from the lab, and it is apparent that this tumor is what we call an infiltrating adenocarcinoma. These tumors make up 75% of pancreatic cancer cases. Adenocarcinomas form glands, which are the collections of cells surrounding an empty space in the photo. These tumors can grow large enough to infiltrate nerves, which could be the cause of the back pain our patient is experiencing. These types of tumors frequently metastasize or spread to the lymph nodes, which will make the tumor unresectable, meaning unable to remove. Luckily for Catherine, her tumor has not metastasized, so if we act quickly, we can get her cancer under control and on the way to being cancer-free. As shown in the images, these cancer cells can be seen to form small ducts, causing scarring and inflammation labeled by the arrow. We can now compare the images of Catherine's tumor to that of a healthy pancreas. The pancreas is mainly composed of three cell types: islet cells, acini cells, and duct cells. These cells are responsible for things such as producing hormones like insulin, as well as enzymes needed to digest food. In a pancreas with cancer cells, these ducts can become blocked, as well as islet and acini cells not being able to function. By examining Catherine's pathology report, we've determined that her tumor is in stage T, meaning she only has the primary tumor, which has not yet infiltrated other areas of the body. The characteristics of cancer cells are all displayed in the pathology report. The cancer cells have shown evasion of apoptosis, or death, as determined by the failure of the AKT2 and the TP53 genes. The KRAS gene's malfunction demonstrates the limitless potential for replication, self-sufficiency in growth signals, and insensitivity to anti-growth signals. We can also see that the tumor has gone through angiogenesis, meaning blood vessels have formed that are feeding the tumor and allowing it to grow and potentially invade other tissues, which Catherine's has not yet. Pancreatic cancer became even more evident when noting the changes in physical properties between healthy cells and cancerous cells. The first difference is in the cytoskeleton, or outer shell of the cell. Changes in appearance of the cytoskeleton change how the cell interacts with neighboring cells and affect adhesion and movement, called motility. With this alteration, a large mass, or tumor, can form and does not exhibit contact inhibition, meaning that although the mass is surrounded by other cells, it is able to disregard and grow in size. In cancer cells, adhesion is decreased, allowing the cells to move to other tissues, causing metastasis. In addition to cytoskeletal changes, nuclear changes occur as well, altering the shape and organization of the nuclei, which becomes useful in staging tumors. In pancreatic cancer, enzyme production is also affected. Cancer cells are able to secrete enzymes that allow the cells to invade neighboring tissues. These enzymes have the ability to digest barriers, leading to migration of cancer cells and potentially forming new tumors. Unfortunately, the prognosis for pancreatic cancer is poor. Because the early stages of pancreatic cancer are relatively symptom-free, treatment isn't started until very late. Without treatment, the prognosis is about 3 to 5 months. However, with immediate treatment, life expectancy can increase to 11 to 15 months. Pancreatic cancer is the fourth leading cause of cancer-related death in the U.S., leaving many clinical trials available to patients. We use clinical trials to test new treatments or combination of treatments for diseases to determine their effectiveness. Inactive treatments and placebos are never used in clinical trials. Patients will either receive the standard treatment of chemotherapy and radiation, as well as potential surgery, or they will be subjected to possible new treatment as well. We plan to give Catherine the option to participate in clinical trials or receive standard treatment for her cancer. Now that we have reviewed Catherine Dexter's case, we can address the patient and explain our findings to her. Hello, Mrs. Dexter.
Hi, doctor.
So you're aware of our diagnosis of pancreatic cancer, and I'd like to explain your situation in a bit more detail to you.
Please do.
As you may know, cancer is a term we use to describe diseases where a cell divides without control. We know that your tumor is cancerous because it shows many of the hallmarks of cancer, such as growing without a go signal and failure to respond to a stop signal. Other hallmarks include cells avoiding death, unlike normal cells, and angiogenesis, meaning that the tumor is forming blood cells which are feeding it and allowing it to grow. This cancer cell's ability to invade tissues and form tumors that use nutrients in your body is what's making you sick.
So why does this happen?
We believe it has to do with malfunctioning genes controlling cell division and cell death. With these two types of genes malfunctioning, cells may divide uncontrollably, as well as nothing telling it to stop dividing or causing the cells to die, which creates a tumor. Carcinogens such as smoking may increase your risk, as you are a heavy smoker.
Right. So what am I looking at for treatment options?
The typical chemo, radiation, and potentially surgery.
So surgery is an option?
It is, because your tumor is only in stage T, which is the first stage, meaning that it has not spread anywhere else in the body. We call this a borderline resectable tumor, meaning that if it's successfully removed, cancer could be eliminated.
And if it's not, can I still do the chemo or radiation?
Absolutely.
What are the side effects to that?
The side effects for chemo can include hair loss, nausea, blood clots, tissue damage to the healthy cells, fatigue, infections due to the lowered immune system. Memory and concentration problems and pain are all possibilities.
So what's my prognosis looking like?
Without treatment, 3 to 5 months. With treatment, life expectancy can increase to 11 to 15 months.
Is there a chance I'd pass this on to my children?
While there's no familial form of pancreatic cancer, 5% of patients have a genetic link to the disease, so it's highly unlikely.
All right, thanks for talking with me, doctor.
No problem. Unfortunately, 3 months later, only 1 week away from beginning surgery, Catherine Dexter passed away. This serves as a reminder of how serious pancreatic cancer is and how pertinent it is for cancer research to continue.